So as you know, my name is Jessica Guidry. I've been at Kitsap Public Health District now for, in April, it'll be 14 years. And previous to that, I was in the Public Health Emergency Preparedness and Response Program. And today, I'm here to talk with you as Lenny mentioned, my new role as Equity Program Manager. And I'm going to go and share my screen because I have a lot of content I would love to share with you all. And Lenny, I'm going to do my best to keep an eye on the time, but I'm also happy to talk with Lenny about getting these slides on our internal page for the league, because there may be questions you have and things you might want to look over. So in terms of our discussion today, there's some basic things I want to address first that will build upon kind of the meat of our discussion. So first, talking about what is public health, and one thing this pandemic has done, for better or for worse, is to really shine a light on public health. And often we joke in public health that people don't know about us until something wrong has happened, until someone has gotten a sexually transmitted disease. And, to track that, or unless someone has a septic system issue or whatnot. So I'll talk a little bit about that because it does relate then to, as we talk about our resolution, declaring racism as a public health crisis. What does that mean? What does public health have to do with racism or vice versa? I'll talk a bit about the resolution, what is in it. And I'll also give a little bit of national context in terms of the number of agencies that have these resolutions, and then talk a bit about what's going on now and kind of what our next steps are. And as Lenny also mentioned, I will talk a little bit about COVID in here because she's absolutely right. COVID really put the issue of racism to the forefront for us. For years, public health has known that there are racial inequities in various aspects of health. So with that, so really quick, what public health is, and there are a lot of definitions, but this is one from the Institute of Medicine, and I think it's a good one. And hopefully you all can see this. And if you want me to make this larger, please let me know. But the Institute of Medicine describes public health as what society does collectively to assure the conditions for people to be healthy. And I love this definition for so many reasons. That the idea that it's a collective action. It's not just one governmental agency. It's not just government. It is a collection of individuals, organizations, systems that help support the public being healthy. And really, we look at the conditions for people to be healthy. And I'll show you a slide in a little bit of a model that public health folks look at in terms of what affects health, but it's not just health. And it's not just about exercising and eating healthy. There are conditions that support health. And some of the key activities that public health agencies do are things like assess and monitor health trends. What health issues do we have in the community? In order for us to know this, we need to look at the data, and we also need to talk to our community about what's going on. What are the health concerns that we need to be looking at? How prevalent is a certain disease, or how many cases of COVID do we have? So data really matters. Also implementing evidence-based strategies to address health problems and promote health. And so evidence-based is really key, and it's something that most public health practitioners really look at. What does the literature say? What have other organizations done? And have they actually evaluated what they did to see if it actually was effective? And can we learn from them? And then in addition to that, we investigate and address disease outbreaks. No other organization does that. But other organizations may help educate the public on healthy behaviors or on conditions to promote health, and then also on like more instant information on health, more the current health issue like COVID, for example. We also develop, champion, implement policies, plans, and laws. So we're not so much, I think a lot of folks traditionally see public health as a direct service provider. We provide vaccines, family planning services, but over the years, as funding has decreased, really we've had to look at, okay, what is truly the role of public health? What is foundational to us? And for us, we get the best return on investment by looking at what policies can we promote to help promote health. So whether it's preventing smoking at public places or supporting seatbelt laws or whatnot, to really look at population health. We use regulatory actions. So yes, for example, I think a lot of people know that we have food inspectors who go to restaurants, try to work with restaurants to make sure they follow laws to help keep people healthy. And then we have to act if laws aren't followed. Also, and this is something that, to be honest, we are still, we don't have dedicated staff to look at this, equitable access to healthcare, but with Susan and Carolyn involved, like our health officers involved in, I believe the group that they're working on to look at healthcare options in Kitsap. And he actually pulled me into that recently. So that is something, even though we don't necessarily provide all healthcare, we don't provide healthcare. We have to assure access, especially when we look at, like, for example, COVID. We can't be the only vaccinator in the county, but what we should do, and I think what we have been, really trying to do, is look at where are there gaps, for example, in access to vaccination, and how can we bring partners together to address those gaps, or as a last resort, do we have to be the one to fill that gap? And then probably one of the most important things is that community engagement and partnership piece. And it's not just about surveying community members to ask their opinion for stuff, but it's also being available, being present, so people know public health is around. And I know Pam and some others have a background in public health, but over the years, like, we've invested less in health educators. When I started, we had people who would go to health fairs and talk about public health. But as funding decreased, we had to really focus on policy. But COVID really showed that, that face-to-face connection, people seeing a public health worker at a community fair does make a difference. Even if they're not an expert, like, I'm not an expert on drinking water and septic systems, but I know that we address them, and I can definitely hand someone a flyer. I can read someone a flyer if they aren't able to read it. So I think this is really pointing to the fact that we can't just only use social media, even though we have limited resources. We do have to be very strategic about the meetings we go to, the events that we go to, so people do see and know that we exist. Our mission statement is pretty straightforward, but we prevent disease and protect and promote health of all persons in Kitsap County, whether or not you're a resident, a visitor, citizen, non-citizen. If you're in Kitsap County, we want to take care of you. Now, when it comes to disease prevention, like COVID, typically that's done by the person's home county. So some quick facts about the health district. Some of you may know that we've been around since 1942. And the second bullet is going to be outdated second half of this year, but we're currently governed by a public health board that consists of all three of our county commissioners and representatives from all of our cities. We have city mayors on our board, but for Bainbridge, I believe it's, I can't pronounce her name. It's I think a Greek sounding last name. Kristen H. And she's part of the Bainbridge Island Council. This is going to change, though, due to a state law that I believe was passed early last year. So you're going to see that we have to have an equal number of elected officials and non-elected officials on our public health board. We have to have some medical professionals. It is mind-boggling to know that but before this law, there was not a requirement to have a medical person on the public health board, and they're making health policy decisions. So we have to have medical professionals. We have to have representatives from the community, and our public health board is currently working on that. And in particular, the county commissioners are working on that effort, and that's supposed to be starting sometime in the middle of this year. So I do invite folks, if you're interested in this, to please look at it. And I think, if I'm not mistaken, this law passed because of all the politics involved with COVID and just the contentious, really difficult nature of the relationships between these boards of health and their public health agencies. And so this is really trying to take some of the politics out of it. But I've heard some stories about how that isn't always the case, and people are able to still not necessarily follow this rule by its intent. We're a special purpose district, so some folks do think we're a county department. And I mean, I'm kind of nitpicky about this, but we are independent from the county. So we make separate decisions from the county. We have our own HR, our human resources, IT, our own leadership. We report directly to the commissioners and the city representatives. Not, we don't have to go through the, the county administrator and whatnot. We now have 140 employees. There have been times in the health district, so I'll tell you how long I've been here, where we had closer to 90 people, but COVID, we hired a whole bunch of people due to COVID. And I think we're lucky that we haven't had the leadership drain that other public health agencies, although we did have a health officer transition during this pandemic, which was fascinating. And then we've got 3 divisions, and I won't go through all the different programs we have, but I mean, these are programs like parent-child health. So I think I saw some folks from our birth 0 to 3 group. So you may know our parent-child health program. We have communicable disease, COVID, HIV program, epidemiologists, and others in our community health program. And environmental health, that includes restaurants, living environments, sewage, septic, drinking water, and then surface water quality like lakes and all of that, and then our admin services. So I share this to give the context about our agency. So when we talk about the resolution, I can talk more about why we're thinking the way that we are. So I alluded to this earlier, but this is a model. Most experts agree that health is impacted by more than just health. And this is a model that a lot of public health folks look at. And here it looks at how health behaviors, so exercising, your diet and whatnot, people estimate that it roughly makes up 30% of what your health is like, and if that makes sense. Clinical care, only 20%. But it's when you look on the left, when you look at social and economic factors, 40%, and then physical environment, 10%. And when we think about racism, when we look at, and on the right, you'll see that there's an orange box around the social and economic factors: education, employment, income, family and social support, community safety. Racism affects all of those factors. So not only, so racism impacts healthcare, access to healthcare, whether or not people trust their healthcare, whether or not people have healthcare providers who look like them, who understand their culture. So racism impacts that, but then also impacts all these other social and economic factors. And racism also affects, physical environment, where people are able to live, access to housing. And a lot of folks have heard of, residential segregation and redlining. So that's, and then also when you think about environmental justice and what communities are most affected by pollution, they're often communities where you see higher percentage of people of color. So that's a kind of a broad connection. But I think a lot of times people, when they're like, well, racism doesn't affect health because, health is about healthcare. And so that's not totally the case. So at Kitsap Public Health, back in 2017, our epidemiologist created a health disparities report, and we haven't done it since. And my hope is that we have more epidemiologists now than we've ever had. We have one actually that's assigned to our equity program and to work with me. And one of the biggest things that we need to look at moving forward are the disparities in health outcomes, not just by race, but also what can we pull by gender, by income. I think it's tougher when you look at gender identity because you often see male, female, and that's based on how data is collected. But in the future, if we're able to pull like even, non-binary or and other identities as well. But even in 2017, we saw disparities. We saw disparities in terms of household income. And here you'll see in that first bullet that the median household income for American Indian and Alaska Native, Black, Hispanic, and multiracial households is at least $10,000 below that of white non-Hispanics. We saw racial disparities when it came to education and with like high school graduation rates. They're at least 5 percentage points lower for Black, Hispanic, Native Hawaiian, Pacific Islander students compared to white and non-Hispanics. And the thing is, there's no biological reason for this. So people can't say that, oh, it's because, one race is, naturally more superior. Yes, the people believe that decades ago and people still believe it nowadays, but the science disproves that constantly. What's also unfortunate is our league members know this especially, that early childhood education is so important and being ready for kindergarten is so important. But here you see that readiness for kindergarten, there's a disparity there. So at least 14 percentage points lower for our communities of color compared to white non-Hispanics. And again, there is no biological reason for this based on race. Race is a social construct based on how groups of people identify color of skin and they attribute characteristics of color of skin. There's no biological support for it. It is a social construct. So even with healthcare access, and this is, 7 out of 10, Latina and Black pregnant women access prenatal care in the first trimester, which is such an important time to get healthcare, compared to 8 out of 10 whites. So even 8 out of 10 whites is still something that we need to look at too, because ideally it would be 10 out of 10, but there is a disparity there. And then, and we see this nationally, when we see, in Kitsap, non-white babies are nearly 2 times more likely to die in the first year of life compared to white non-Hispanic babies. And then you see life expectancy also being less for our Black neighbors as well when compared to white non-Hispanic. So this is data based in 2017. We don't have updated indicators yet because a lot of our focus has been on COVID, but we have seen disparities when it comes to COVID. So this is data that I pulled yesterday. Actually, I pulled this morning, but it was updated yesterday on the health district's website. So throughout the pandemic, we've seen, when it came for example, and when I say this, I don't mean to stigmatize our communities of color. It is not their fault that they have higher cases, and so this is not meant to be like blaming at all. But just when we just look at the statistics, we see that a higher percentage of COVID among our communities of color, and especially in Kitsap, we saw it most. It was really apparent with our Hispanic, Latinx communities. With our non-Hispanic, non-white, and I think unfortunately that Asian and all that was lumped into that. We did see some disparities there. In other communities, it was much more profound. And again, with cases, a lot of it depends on who gets tested, because that's also a limiting factor here when it comes to when we look at cases of COVID. It's all about who gets tested and access to testing. And so the second part, you'll see percentage of cases by race. So you'll see, so on the left, you'll see that we provide, okay, what percentage of Kitsap County is white, and that's the red bar there. So, and I'm sorry that the format looks off here, but it's around 75 point something percent of our population is white in Kitsap County. But then when you look at our cases, 74.7. So that seems about right? When you look at our community and that. But then when you look at, for example, our Hispanic community, they make up around 7.7% of the county, but 13.8, so almost twice as many, of cases. We also see a bit of a disparity also, with non-Hispanic Black, and you can't really see it as well, but they make up 3% of our county, 4% of cases. So there's a higher proportionate when we look at cases. What's interesting is when we look at non-Hispanic Asian, they make up about 5.9% of our community, and they made up about 4% of cases. And then with Native American, Alaska Native, it's proportionate. And then when we look at vaccines, so and some of y'all may have seen this, and this data looks at who has initiated vaccine, which means who has gotten their first dose. These numbers are, so I'll do that. But you'll see here, for example, when we look at children 12 and older, so they were the ones who got access to vaccine first, 61% of them, of white people in Kitsap County, 12 and older, have at least gotten their first dose of vaccine. But, when you look at Native Hawaiian, Pacific Islander, that's 91%. So that's amazing. But then you'll see, for example, like with our Black and African American neighbors, only 51% of individuals 12 and over in Kitsap County have gotten vaccinated. So there's still to this day work that we need to do to build trust, with the community, really hear what it is that they're concerned about, and continue that relationship building. This is not something that can happen overnight. We have done a lot of outreach, and I can talk a little bit about that, but there's still a lot of work to be done. And there's work that we can do locally, but there's also, things that happen at the state and national level that also impact our ability to outreach as well, and the messaging and how clear we're able to talk about issues. So one of the things I'm really proud of, actually, and public health often we're guided by funding, and over the years we've had programs come and go based on funding, and that's unfortunate. And I think now public health is looking at funding, and they've been doing this for years, trying to figure out how can we have funding for priorities where it's not just reliant on whether or not politicians see that an issue is important. So like with tobacco, we used to have a lot more funding for it. So we had staff who worked on tobacco work. We had staff because we had funding that worked on injury prevention. Currently, we don't receive funding for things like opioid use disorder work. So a lot of it is based on funding. But for COVID, public health agencies have received funding for COVID. This, because of the disparities, we have really prioritized having dedicated staff to just look at the inequities. Because if you so for example, I was the first incident commander for our response for COVID at the health district, meaning that I was the first project manager for it. And we knew that there were disparities, and we slowly, said, okay, we have staff who are working on outreach. Yes, let's have them do equity. But then as time came along, we got buy-in, and we were able to actually hire someone to just look at the disparities. So that was their whole purpose. Because when you add roles upon roles upon roles on people, people can't do everything to the way that they would like to. So her name is Holly Bullstead. I know several of you know her. She pulled together a vaccine equity collaborative. So this is a group of individuals who have provide consultation to the health district and who have helped get the word out on vaccination efforts, on vaccine misinformation, and they have helped provide us with really important insight, because we are we kind of are in our public health, I don't call it, maybe a public health bubble, but that's been incredible. They've, with vaccination clinics, we've looked at, how can we bring vaccine to individuals experiencing homelessness, people who may not speak English, or people who may be distrustful of healthcare. So we've partnered with various organizations, Marvin Williams Center. We're going to be at the MLK event at the fairgrounds on Monday. We've also worked with churches and others who have people they serve who necessarily can't make the time to go to a vaccination clinic during a work day, or have other barriers. We share information. We've done a lot of translating of our materials, and this is something that we've never really had the resources for, and we've really prioritized in this response. And then we've also done key informant interviews, so really reaching out to community members to ask them their perspective. Yes, there's been national studies on people's opinions about vaccine, but is there a slightly different perspective in Kitsap? So that's where this comes in. And we did look at individuals where there are communities that had lower vaccination rates. In Kitsap, we saw lower vaccination rates among our younger, 19 to 34 folks, maybe the folks who see themselves indestructible. We saw lower numbers in our African-American community, Hispanic and Latinx community. And it was meant to be a non-judgmental. It was not at all meant to change minds. It was just to really hear what the perspective was. So we could learn. And so, for example, one perspective that we got which is really an interesting one, was, hey, you're always talking about get vaccinated, but what other risk reduction can you talk about if I've made my mind about vaccination? Which is a really good comment, because, there are many ways to, yes, vaccination is key, but there are other things that people can and should be doing to help prevent the spread of COVID. So we've got that. So as we've been doing our community work, and Holly in particular, she did some outreach, we had some tough feedback from our community saying, hey, yeah, you guys want to come talk to us, but where have you been? And how come you all aren't declaring racism as a public health crisis like others are? And I'm really proud of the fact that instead of getting defensive, our leadership asked, okay, well, what does this mean? And they assigned staff to say, okay, look into this. Look at what other communities have done, other communities that have similar resolutions. How did it help improve? So our staff pulled together draft language for that resolution. And I'll talk a bit about that process. But I think this feedback we got from Erase Coalition, I think a lot of you know who that is, but Erase is the Equity, Race and Community Engagement Coalition, and specifically the health systems team from that Vaccine Equity Collaborative I mentioned to you. But there was a recognition from these folks and from the health district that, yes, we can look at this, but it has to be a first step, and it can't be the end all and just, checking a box and saying, oh, hey, we declared it, all is good. So, and those last three bullets are actually, talked about in the resolution itself. So early last year, Holly and others, our equity, so Holly's our vaccine equity liaison, and others drafted this language. They got feedback. They sent the language to both the Suquamish and Port Gamble-Swellam tribes, to various coalitions and community partners, and asked, what do you all think about this? And I know at least one of the tribes gave us quite a bit of feedback, which was amazing. And we then worked on that language with the board, and they passed it, I believe in, you think I would know this, I believe April or May of last year. And it was a really big step for us to do this. And before I go into what that resolution talks about, I just wanted to just reiterate some of this, and some of this I already mentioned, but because we've gotten feedback from community members who think that we're out of our minds for declaring racism as a public health crisis. But when we look at what the definition of a crisis is, it's like it says here, a time of intense difficulty, trouble, or danger, and a time when a difficult or important decision must be made. Racism is a crisis, and it's a public health crisis because racism affects health. We have gotten feedback, well, you all share trends, but correlation does not equal causation, which is true. However, there are research studies that look at when people experience discrimination due to race, how that impacts their health. And it makes a difference. There are studies that show that even when you look at educated Black women, how they have worse outcomes, especially when it comes to their baby's birth weight compared to non-educated white women. So it's like, even though these women are educated and have jobs, they still, and when you look deep into it, it's that constant stress of being discriminated against. But then also, like I mentioned, the access to healthcare, the distrust of healthcare, the fact that even to this day, healthcare providers, and there's a survey I saw, it might have been from a couple of years ago or last year, where even medical students think that Black people have a higher tolerance for pain. And there's no biological reason for this, but this is based on our history with slavery, right? So there's a lot that we have to unpack with this, and there are health inequities, and it's not the faults of these communities. There are systems in place, and they're very difficult questions, and they're very difficult issues that we need to address together. Something that I flat out say, and this is not a bold statement, but it's bold for my agency, is that racism is a social determinant of health. Historically, people would say that race was, but it's not people's color of their skin that affects their health. It's how they're treated based on the color of their skin. It's the access to resources. It's the stress that they receive. And I mentioned those studies, and the time to act is now. And that's where, the health district, our leadership believe this. So, and this is something that we really discussed with our, and I'll skip this because I already mentioned that. In terms of definitions of racism, most people think about interpersonal racism or a person discriminating against another person, but it's also about a system of structuring opportunity and assigning value based on the social interpretation of how one looks. And there's a lot of definitions of racism, but this looks at unfair disadvantaged, people of color, and then also it saps the strength of the whole community through the waste of human resources, because not everybody has access to those opportunities and can actually participate in government in various fields. So, across the country, people are declaring racism as a public health crisis. And this is from the American Public Health Association. These agencies know, and Kitsap Public Health knows, that this is just a first step in addressing this. So I'm going forward a little bit. So I checked this yesterday, and according to the American Public Health Association, there are at least 233 city, county, and state declarations declaring racism as a public health crisis. And in Washington State, there's at least 8. And interestingly, Jefferson County had their declaration before we did. King County did, Snohomish, Spokane, Tacoma, Pierce, Thurston, and Whatcom. So yes, most of these jurisdictions are in Western Washington, but it's not just a big county philosophy. So I mentioned a little bit that this time frame. So yeah, so May 4th, the board passed a resolution. My position was posted. Now, I didn't get started in this program fully until about late October, because I had when I got the position, I had 2 other jobs at the time that I had to turn over and complete to make that happen. So really, I've been working full time on this since October, November. And in the resolution, there's a whole list of commitments in there. So that if you read the resolution, there's local data in there and stating the case about why racism is a public health crisis. And in the commitments that are listed, they can be put into 5 buckets. So one is about reviewing policies, procedures, and programs through a racial justice and equity lens. So basically what that means is that as an agency, we need to have a list of questions that we ask ourselves about whether it's like a vaccination policy, or hey, are we going to, so like, for example, the state's going to give us some at-home test kits that we distribute to the community. So we need to ask questions to ourselves about how can we make sure that we are addressing gaps and that we are truly, and that we're addressing health inequities with these programs, and that we're not further causing harm and perpetuating racism. So this is something that there are various lists of questions out there that we can, assessment tools that we can use. So it's a matter of us choosing one and using it. And also making sure that we incorporate these activities into our work plans. Looking at our workforce, it does talk about recruiting a diverse workforce, but it's interesting because I was talking with a colleague, and I know people, there's a lot of pushback and concern about, hiring diversity just for the sake of diversity. And I was talking to a colleague of, not from my agency, a couple of days ago, and she really described it well about if you create an agency culture that is inclusive, and not just inclusive of race, of different physical abilities and disabilities, of gender, gender identity, sexual orientation, what have you, then you will likely have more diversity once you build a workplace that helps support that. So I thought that was profound. This resolution also, and I promise I'll have a couple other slides because I apologize, I know I'm over my time. It does require the health district to take training in health equity, cultural competency, and anti-racism. And one of the reasons why this work has to take, it's not quick work. I can't just tell our staff tomorrow that they have to take anti-racism training. There are trainings that I'm working on trying to get in place, things like implicit bias that will help build the foundation for anti-racism training. It's like if you're going to train someone to do surgery, for example, they should first, and I'm making this up, so I apologize, I'm not a medical person, but you need to teach them first biology, right? So before talking about anti-racism, first talking about empathy and teaching people about what people of color are experiencing, and having people of color share that, not just, well, I identify as a person of color, having people share their stories themselves. We have to have a structure to support this. It's not enough to say that we are declaring racism as a public health crisis. We need to actually allocate resources. So the fact that there's my position, I'm currently the only person working on it. I'm hoping to work on getting at least one other staff member, at least initially. So we need that structure, but we are required to have the committee. We're also now with community partnerships, and I think this can be frustrating, and I understand it's very vague in our resolution. It says that we have to co-create solutions to address structural inequities and promote policy and system level changes. It doesn't say what that looks like, but that's where it's one of my roles is to understand and to learn what priorities have our community already addressed. Are there priorities that we haven't talked about yet? So instead of me just coming up with, okay, we're going to look at housing, or we're going to look at access to healthcare, we really need to look at this, and we really need to look at what systemic racism looks like in Kitsap County in terms of the data, so we can figure out then how can we measure progress. We need to know what our starting point is with access to housing by race and other factors. Even incarceration in Kitsap County, are there inequities there? And then our Board of Health, so our governing board also has some requirements when it comes to working with tribes, and they have to stand for nonviolence and inclusion for environmental restoration. If y'all are interested, the resolution is on our equity homepage. And also, I did a similar presentation with some other groups, that's also on here. If you want to see some data, that's on here. Also on our website, you can actually see the demographics of Kitsap public health staff. And we actually do pretty much reflect, demographically speaking, the county. And actually our management team is a bit more diverse when you just look at our management team. So in terms of my priorities, and this is probably more what y'all are interested in. So to be honest, I have to first really clarify the program purpose and scope, because my position was not titled the Racism as a Public Health Crisis Program Unit. It wasn't even racial equity program. It is the equity program. So what I need to make sure that I'm clear with my leadership on what it is and isn't. And, it takes time to add that clarity, because I also need to be able to compare what other programs are doing and make recommendations. Also, we can't be everything to everyone, and public health can't be the only agency to work on racism, and we're not. There are other organizations that are working on addressing and trying to dismantle systemic racism. But we also have to take a public health approach. But are we all even on the same page of what that means? And the way that the CDC defines it, and when you look at like the public health approach to addressing gun violence, there are 4 steps. One is to actually figure out and define the problem, and that is data collection. And and as our country, when it comes to gun violence, we've had trouble with collecting data due to a lot of political reasons for that. But we need to, so that's where we're really looking at what systemic racism and systemic inequities look like in Kitsap County. So we know our starting point. But it's also collecting stories and hearing from our community, not just only looking at the data. We need the context, and we need, also, we've been told by community members that just looking at data is very colonial. It's a very, white supremacist way of thinking. So also other ways to collect information. But it's looking at then what are some effective ways to address these inequities, and then implementing them and evaluating that. So we have to use our public health approach. We need to be really clear on when we need to build those partnerships. Our staff have to be on board. And this takes time because, just like in any organization, our staff have varying political views. And we have staff, and well, our community, I imagine, and people I know are exhausted from the pandemic. I know our staff, just like healthcare workers, just like teachers and other professions, are exhausted because of how we have to address the pandemic in our work life. We don't escape the pandemic at work. I'm not saying that a lot of people do, because it's hard to escape. So it's also really being strategic about how I can help bring people together. And because I've gotten feedback from my colleagues about not wanting to be made feel, that if they haven't go to anti-racism training where they're made to feel guilty about being white, they don't want to go. And so I have a lot of work to do in terms of building relationships, even internally within my agency, so folks know what our intention is. It is not meant to shame. We want to draw people in. We have to have hard conversations, but it's so we can do better, and we can do better to our colleagues and to our community. Building community partnerships is really huge, and that takes time. And I mentioned identifying the incentive inequities, but then also it's this policy, procedure, services review. And something I'm really hoping, what I mentioned earlier, is that we can advocate when looking at our new public health board structure, looking at that from an equity lens. So I'm hoping to give some recommendations to our leadership about that. Also, though, we're due for a new strategic plan. So I'm hoping to also work with our leadership on what that looks like, and making sure that we are really thoughtful about equity, and that equity is driving all of it. And when I say equity, equity and equality are different. Equality, and this is a really great analogy where, like, equality is like giving everybody a size 9 shoe, whereas equity is asking people, oh, you need shoes? What shoe size do you wear? What color shoes do you like? What do you use your shoes for? Do you need more of a walking shoe or a running shoe or this kind of shoe? So equity is about looking at what barriers people are facing in order to live the most, their best life, however they define their best life. And so for us, it's about taking out those barriers, a lack of access to education, lack of access to healthcare. And a lot of what you all are doing in your various committees are doing that and are addressing equity. It is an equity, is, even though we have a program for it, it has to be ingrained in every program. You can't just check off the box. Oh, if I talk to Jessica and she gives me some tips, that's equity. No, equity has to be at the very beginning of when we think about doing a public health activity, how we talk to people. And it has to be part of our culture, not just an activity where there's a checkbox. So with that, and I'm so sorry, Lenny, I went over, but I'm going to stop sharing my screen. I have the slides if you all need it, and I'm happy to answer any questions that you'll have.
Well, thank you, Jessica. I know we all really enjoyed that. I was happy to let you go over because it was